Good afternoon, everyone. So, Dr. Tarun has already covered in detail a lot of finger replantations, so I'll try to direct my talk more towards the more major replantation. So, it is when we talk about amputations, it is a complex injury. It is not just vascular. There is all the other structures are accordingly injured. And replantation, whenever feasible, should be the best reconstruction. So the patients usually get injured by multiple ways, can be accidental trauma due to roadside accident, industrial accident, everything. And usually they are brought in these kind of stages to the emergency wards. So what should be our goals? When we talk about this, the patient has presented. So we have to, the first goal immediate is to revascularize with minimizing the ischemia. The second thing when we are talking about major replantation is to also prevent and minimize the reperfusion injuries and performing the primary repairs of nerves, nerves, muscles and tendons to the maximum possible level and giving them the wound coverage required. The intermediate goals should be performing the secondary repairs or secondary procedures which could not be performed initially and maintaining supple joints while everything else recovers. Long term, we are aiming at a sensate and a functional limb. So, the first goal is the minimizing of the ischemia time. In major implants, the more the muscle in the amputated part, the less is the time, less time we have. Time saved is we can save more muscle and more function. And reperfusion injuries, the chances also increase with increasing time. So, how do we minimize the ischemia time? Quick decision making, teamwork, stepwise surgical approach, and some temporary vascularization measures can be used. So a lot of time is usually spent in these kind of amputations when we are wondering whether we do it, we don't do it. We quickly have to assess the limb and the systemic injuries, and you have to decide first, and then the patient has to decide whether he wants to go ahead with it or not. So you're deciding how we decide is usually multiple factors. What is the age? Children, we try to do everything young and advanced age, we usually don't go ahead in many cases. How the present time of presentation, is it early, is it within the window, or we have lost too much time already. The level of implant, whether it's a finger, it's a hand, it's a forearm, and what the important factor which is there is the type of injury which we are encountering. It's a crush or avulsion or a mixed pattern, and how was the part prepared. So based on these, you decide. And there are obviously contraindications also, and everybody is usually aware of this. Hemodynamic instability, systemic injuries, multiple injuries, and so on. So we decide based on what are the indications, contraindications, what a particular case has presented. So, and what are the expected outcomes we are usually looking at? With advances in microsurgery and dedicated centers, we have been able to achieve success rate of about 25% in cut injuries and about 50% in crush components. And the recovery of motor and sensory functions is up to, we can expect up to 50% recovery. And it takes time, it takes major implants, about 2 to 3 average number of surgeries and 6 to 9 months of time, and obviously the cost involved. So patient has to decide also. Apart, once you decide, then you talk to the patient and what are the expected outcomes and whether he wants to go for a prosthesis, the cost and time of work. So once everybody is set, the patient has said yes, you have decided, then you have to kickstart and you have to minimize the ischemia time. So first of the minimum, the best approach would be a teamwork, and in the emergency team can take care of the antibiotics, consent, the X-ray, PAC blood, and the OT teams can simultaneously prepare the theatres, while the surgical team can start with the dissection of the part. So we usually do it on a bench and try, if possible, try to put the part on the ice to further minimize the warm ischemia time, and then wash, divide and dissect. We always dissect the structures, divide whatever is looking non-viable, in some time saving strategies, we can take core sutures to the tendons already on one side, do the fasciotomies and distal bony fixation. The bony fixation distal part can be done, and plus minus the shortening, which is required on the amputated part. So, and there are measures to minimize the temporary revascularization measures. And this is how do we minimize the reperfusion injuries. There are 2-3 strategies which are involved. Removing the amount of muscle in the distal amputated part, the less amount of muscle in the distal part, and we can remove so that it is more likely to get necrosed and leads to infection and reperfusion. So if we remove the muscle, more muscle from the distal part, we can reduce reperfusion. And then there is a method of flushing. We cannulate the arteries and veins, arteries in the distal amputated part. Flush it with heparin saline. This saline will come out through the veins, and we can do it for 15-20 minutes before actually going for the. It will wash out the. It helps in washing out the metabolites which have accumulated due to ischemia. So some centers have been using ECMO also to revascularize the part while the patient is being stump is being dissected and the patient is being prepared. So it can be done in emergency room as well as in the theatres. Once the patient is in OT, we can quickly move on to the anesthesia and catheterize the patient, apply tourniquet whenever possible. Temporary shunting is another method while we are dissecting the stump and preparing for osteosynthesis. Temporary vascular shunts can be used to revascularize the part. And then we simultaneously prepare the stump. Again, the stump will be wash and debridement and tagging the structures. The spurt test Dr. Sarun has already explained, and we cut the nerves where there is to find until we find protruding fascicles from the nerve ends, the snail-eye sign, so on. Then finally coming to the repairs. Most of the functions that we are going to recover, the sensation and the function, are actually dependent on what we do at this point of time. Bone is obviously done first, can be done with wires, screws or plates, but repair of tendons usually is recommended to a good layer repair with a core and epitenoid suture. And sometimes we can directly go for tendon transfers when there is muscular and tissue losses or tendon are lost and we have available donors. We can go for transfers or grafts. And nerves also we can repair primarily whenever possible, use grafts, conduits, and in very distal implants, sometimes no nerve repair can also be an option. And while repairing the vessels, some units are of the opinion that artery should be done first, other units prefer doing the vein repair first. And when coming to the anastomosis, it should be a tension-free and ideally 2 arteries to be done, although one would also could do. So, and there are some centers which prefer no clamps to be used in the distal arteries, digital arteries, so as to avoid any kind of spasm. So as Dr. Tarun also has said, vein grafts we should be very, very open to vein grafts. They are the lifesavers. Any kind of tension or intimal injury, immediately go for the vein grafts. So other options for artery repair can be cross anastomosis. In the digits as well as in forearms, we have 2 arteries. Sometimes there is oblique amputation. One of the arteries is longer. We can shift it to the other side in the anastomosis. Cross finger anastomosis have been described, where an artery can be taken from the adjacent finger and used to reperfuse. Arterial transposition can be done from a non-adjacent digit. Venous arterialization, these are all usually done in distal replants with fingers. And arterialized venous flaps can be used. Veins in the major replants, before starting the venous anastomosis, we usually try to let the blood wash out, some blood wash out after an arterial anastomosis so that the toxic metabolites do not enter directly into the circulation. And about 5 to 10 minutes of washout, then we can start with the venous anastomosis. It can be repaired primarily or with grafts whenever possible. And in distal injuries, alternatives have already been discussed. So sometimes the stump is not ready, it is too infected, contaminated, we are not ready, we want to do it in stages. We can do it.
Can we wind up a little faster?
Sir?
Can we wind up?
Yes, sir. Almost done. We can go for ectopic or heterotopic replantations. So these are the techniques which have been used, accessory techniques with replantation, schizotopic, and bony shortening, vessel transposition, flap cover, nerve grafting, and vein grafting. So wound cover is the next, can be done with grafts or flaps or directly. We have to cover the vessels, bone, nerve, and target more business areas has to be covered. Post-operative the monitoring and anticoagulants we have been using in heparin intra-op and dextran post-operatively. Antibiotic, pain relief, and hydration are important during the early post-op. And we keep on mobilizing till we are expecting recovery of functions. And many a times we require secondary procedures like if bone is in non-union, tendon transfer, penolysis, nerve grafts. So in this patient that we are showing, we have done a free functional muscle transfer with gracilis muscle along with sural nerve graft for the median nerve. And distal replants also already been discussed. They are technically more difficult, but otherwise we get more time and to do them, and they are more rewarding. The final goal, as we have discussed, was a sensate functional link. But the outcomes are dependent on type of injury and level of injury also, which we cannot control. What we can control is the ischemia time. So we can reduce the pre-hospital ischemia time by creating public awareness. Patients should come fast to you and tell them how to preserve the part properly, and a dedicated team can reduce the in-hospital ischemia time. Thank you.
We don't have time for questions. We'll continue them in the lunch time. I'll now invite Dr. Omar Farooq for his talk on electrical burns, trauma unparalleled. All the speakers kindly to restrict to their time.
A warm good afternoon to all. As we all know, electrical burns are the very devastating injuries, and basically it is an interplay between all these factors which cause the injury, like the voltage, type of current, amperage, resistance, and the path the current takes through the body. So can be a high voltage or the low voltage. And tip of the iceberg phenomenon is the Joule's phenomenon, where the heat is produced proportionate to the tissue resistance, which is most in the bone. So the actual burn, when the current flows through the body, burn takes place from the inside out. So the first effect is the bone, followed by the muscles, nerves, blood vessels, and last of all the skin. So other modes can be the contact burns, can be the where there can be the entry wound, the exit wound, or the arc burns where the circuit is completed when the air particles are ionized and there is a blast of pressure from the arc. So there is no direct contact with the electrical source, but the electrical energy travels from an area of high resistance to the low resistance, and a lot of heat to the extent of the more than 4000 degrees is produced. And flash burns can be there, which usually heal of their own. So coming to the first aid, our rescuer has to avoid himself. We have to switch off the power supply, we have to remove the live wire from the victim, and we have to use the non-conductor. These all we already know. And in the management, there will be the primary survey and the secondary survey. And resuscitation, high voltage burns, except we should expect that we have to measure a urine output of more than 75 to 100 ml per hour. We have to aponize the urine, and the greater requirement of the fluid is there. So the assessment of the peripheral circulation, we do it by skin color, edema, capillary refill, peripheral pulses, and there is a high chance of the compartment syndrome, so the emergency facial treatment should be done for that. Wound care, aggressive debridement is done, and it holds the key. We have to recognize what can be salvaged and what not, and early coverage of the vital structures is important. So debridement, very rarely we can do it in one go. There is usually serial debridement take place, and followed by grafting of the flaps, which can be local, distant, or the free. I will come to a few cases. This is an electric burn of the scalp and the ear. So this is the post debridement, and we have planned a transfusion flap for the same. This is the planning of the transfusion flap, and it is covered. And we have done the moderate anti-bugs for the ear. This is the post-operative picture. This is the policeman who has the electrical injury of the forearm as well as the thumb. We have cleaned a keystone flap for the patient, This is the early post-op. This is the final result. This is the another patient with the electric burn of the hand and a groin flap has been done for that. This is after the thinning of the flap. And this is the result. This is the electric burn forearm and the fingers, where the two flaps are squared, and where there is a random pattern thigh flap for the fingers and the groin flap for the wrist. This is another patient where after the electric burn of the hand, multiple sites, we have done the grafting of the areas and a reverse radial forearm flap for the thumb. This is a child with the electric burn of the hand. This is the entry wound, and after debridement, this is the raw area there, and we have planned a groin flap, and this is after the thinning of the flap. This is the outcome. This is the another electrical burn patient with the involvement of the bilateral upper limbs, and we have planned bilateral groin flaps for the same. Another patient with the electrical burn of the left upper limb, bilateral groin flap, one for the forearm, one for the hand. This is another patient with the electric burn of the whole of the fasciotomy has been done, and we have said there was the wound on both dorsal as well as the volar aspect. We have done a free ART flap, and you can see that there occurred the steel phenomenon after 2 days. Flap is healthy there, but we have to amputate the hand. This is another patient with the electric burn of the left wrist and distal forearm. Groin flap has been done for the same after the fasciotomy has been initially done.
बस लेफ्ट के ठीक बस अच्छी ग्रिप हाँ मैंने कर एक पॉइंट जोर बन एक पॉइंट पेनस राइट एक पॉइंट द्रावियल कहाँ पता राइट में आठ चार जोर
This is another patient with the electric burn of the index and finger and the thumb. Groin flap has again been done. This is the final result. And the patient with the defect of the whole of the upper lip. It was done very early that we have done the arm tube first for that. Later on we have done the classical Narayana flap to get him the moustache from the flap based on the superficial temporal artery. And this is the pre-op and the post-op. This is another patient with the wound on the dorsum of the thumb, where the FDMA flap has been done for the cover. And the patient where again we have done the two flaps from the both sides. This is the patient where the bone was exposed after debridement and the vital structures. We have done the random pattern abdominal flap. This is another patient where we have done the lower flaps for the three defects. This is another patient where the ALT flap was done. This is a boy who was playing with the ball, and while fetching the ball from the transformer, his hand stuck against the transformer and he had a burn on the forehead and the root of nose. And a glabrous flap was done for the same. This is the final result. So take home message is that we should never allow children to play with the electric cords, and we should always use outlet covers for the electrical outlet at their homes. And we should replace the old ungrounded electrical with the grounded system, and we should never stand in the water while working with the electric equipment. So we have to be very careful when outside during the thunderstorms, and there should be awareness programs on the electrical safety, and proper and quick referral from the peripheral areas can save many lives. And there should be proper training of the electrical department workers, as we have seen in our research that very few people among them are using any of the precautionary preventive measures. And we have seen that insulated pliers only were used in only 7 of the patients. That is only 13% of our series. So you can see how carelessly they are working without any equipment, without any even helmets. They are not even using the gloves also, these electrical workers. So, thank you.
Thank you, Dr. Umar. Very nice. I think we don't have time for questions.
Thank you.
So we wind up the session, and thank you, organizing team, for inviting us here. And thank you all the speakers for a wonderful presentation. And thank you all the delegates for patient listening. Thank you so much.
Thank you everyone, and without wasting time, we'll invite the chairpersons for the next session. I thank my co-chairperson, Dr. Farooq, please. I invite the chairpersons for the next section, Dr. Rakesh Jindal, Dr. Ajat Chandru Kapoor, and Dr. Sunil Gawar.
North Zone Nzapscon 2024 sessions. So I invite Dr. Ravi Mahajan sir. I request Dr. Mahajan sir to please come.
So good afternoon. So first of all, I must thank Dr. Jindal and Dr. Guagaba, who has chosen this topic for me. So in fact, I have been talking about most of the time about microvascular surgery and trauma, whether implantations or upper extremity or lower extremity reconstruction. So this time I thought I must talk on something else. So in my experience, actually, gynecomastia, is one of the, as you know, is very common aesthetic procedure being done by, I think, almost all of us. And what I have been experiencing is that in large majority of the patients, we have been able to, get away with only liposuction. So, but whenever I discussed with some of our colleagues, I think many of them didn't seem to agree with me, and then I thought maybe, I'm wrong somewhere. So we tried to get back some of our patients and see that what is their satisfaction rate and what are the results. So I will just discuss with those things with you. So as all of us know, the gynecomastia is a benign enlargement of the male breast tissue, and this is a simple classification which gives different kinds of grades. And what is the goal of treatment is that we should give a normal looking male chest contour with minimal scarring while maintaining the viability of the nipple and the areola complex. And the ideal male chest is not entirely flat actually. There is a defined masculine contour and a natural fold just below the chest, which is predominantly horizontal. So that is what we have to keep it in mind. And as far as the treatment is concerned, the mainstay of treatment, as all of us know, is surgical. And it can be either liposuction alone, it can be liposuction and glandular excision, or sometimes we may have to do the skin excision. But I must say here that, I have never done skin excision in any case of gynecomastia. Most of the time I tell my patients that if it is required, we can do it in a second stage, but none of the patients has ever come back. So most of the time I think skin contracts and the excision is not required in at least the cases which I have done till now. And liposuction advantage is that it's minimally invasive and it improves contouring by feathering the peripheries, and frequently it is used as a single modality, and you can use various forms of liposuction. It can be either conventional, power-assisted, laser-assisted or laser-assisted, and my experience has been only with the conventional liposuction, but those who use laser-assisted, they do claim that there is a better retraction of the skin, but I think the chances of seroma formation are also more in those cases, but I will be talking mainly in relation to the conventional liposuction. So as I said that in my experience, liposuction has been frequently successful as a single modality and particularly useful for diffuse breast enlargement of soft to moderately firm consistency. And it definitely achieves better breast contour with minimal scarring. So if you are able to manage only with liposuction, you will definitely have a better contouring and there will be less scarring also. So when I was going through the literature, I just came across through this article where actually they have compared the conventional as well as the ultrasound assisted liposuction. And what they were saying was that when you are doing conventional liposuction, even in their series, in 61% of the cases, even with conventional liposuction, they have been able to manage only with liposuction. Whereas when they were using UL, they had a conversion rate of 25%, which means with UL they were able to manage it in 75% of the cases without doing excision. But our experience, even with the conventional liposuction, has been even much better. So just to give you an example, this is a grade 2B gynecomastia, and you can, and in this case, I did only the liposuction, and if you see that after I had finished the liposuction, the chest is quite flat, and there is hardly any glandular tissue for me to remove. So if I try to remove any glandular tissue, this I will end up definitely in a deformity. So, and if you see, we have removed around 800 ml and 750 ml from both the sides. And this is on table, and then this is just after 3 weeks, and you can see that the chest is quite flat. So as far as the technique is concerned, that is the standard technique. We do the marking, and I prefer to do it under general anesthesia than infiltration, and then we do deeper liposuction with 4 mm cannula. Superficial is done with 3 mm cannula, and in the glandular region where we feel that there is some kind of a firm or soft gland is there, I use one sharp cutting cannula also, and then the patient is given pressure garments right on the table. So this is what we are using. And this is a small video. So initially you are using pinch technique, when the amount is large, and then, in order to feel it better so that you have a uniform appearance, you can use what is known as palm down technique also. So the only thing is that we are a little more aggressive with our liposuction as compared to, maybe when we are removing the gland. So when I tried to call back some of the patients to see their satisfaction and the results, we were able to have about 28 cases where out of 28, in 26 cases we had done only liposuction, and only in 2 cases we had to do the glandular excision. And most of these cases were in the age group of 21 to 25 and then 15 to 20. And most of them had grade 2, majority had the grade 2 gynecomastia. And as far as satisfaction rate was concerned, so the satisfaction was almost, the highly satisfied and satisfied patients were, most of them were satisfied, and those who were not satisfied, the reason was not that any of the glandular tissue was left behind, it was more because of some excess skin, which was there, and they were having some, laxity of the skin rather than having any glandular tissue which was left. So just to take you through some of the examples, this is a bilateral grade 1 where we have removed 250 ml from each side, and the satisfaction according to the Likert scale was 5, and this is the 4 months follow-up, as you can see. And you can see here that only liposuction has been done, and the chest is quite flat. So this is at 4 months follow-up. Then this is another, this is the same patient in a different view. And then this is another patient, grade 1. Here we have removed 300 and 350 ml, and again the chest is quite flat. So no glandular excision has been done in this patient. And this is the another view. This is at 3 months follow-up. And now this is a patient, who has excess skin. So we have removed 800 ml from one side, 750 ml from the other side, and this is at 3 weeks follow-up. And now if you see, there is only, laxity of the skin which is there. It's not that any glandular tissue that has been left behind, and the chest looks quite flat just at about 3 weeks. And over a period of time, with the use of pressure garments and all, I do expect that the skin will further become, tight. And if required, then we can think of doing some skin excision at a second stage. But as I said, none of the patients has always come back because probably they are more concerned about the bulge and a little bit of loose skin. They accept it. So this is a patient of grade 2A, where 350 ml from each side that has been removed, and this is the follow-up at 3 months. This is another view. This is another patient, and you can see that the flat chest is quite flat in this case, and the contour which you are seeing, I think that is more because of the muscle which he is having. This is a grade 2B. Again, the chest is quite flat, and even the skin has contracted quite well. And this is the same patient. This is at about 6 weeks follow-up. Another patient where we have removed 650 ml from one side and 800 ml from the other side, and this is at 2 months. And you can see in the lateral view that the chest is quite flat, and as you can see in the other view also. And then this is a grade 3 gynecomastia, and here actually, one does feel that one should remove some extra skin also. But I do give the option to the patient, but most of the patients would not like to have any scar, so we did only the liposuction in this case. And again, I think he's pretty happy with the result, and this is just after 1 month. And this is another patient with grade 3, and the chest is quite flat. But it's not that we are able to do it in every case. So as I said, out of 28 cases, in 2 cases we had to do the glandular excision. So what I do is, once I finish with the liposuction, I feel if there is a residual glandular tissue left, then I will go for the glandular excision. So as in this case, we had to remove the gland, because after liposuction, still I could feel some glandular tissue, residual glandular tissue was left behind. But you can see the patient is still not having, doesn't come in the category of highly satisfied, because the excess of skin is still there. So dissatisfaction is more because of the excess skin, which may be there even in those cases where you are removing the gland as well. And this was another patient who was a bodybuilder, and there was hardly any fat actually. He had only gland, and we removed only 50 ml from each side. With liposuction, it was more of a firm gland, so we had to remove the gland in this case. So these were the only 2 patients out of these 28. So what I would like to conclude by saying that a large majority of the patients of gynecomastia, in my opinion and in my experience, they can be treated with liposuction with high degree of satisfaction. And the grade 2, B and 3, they can have some skin redundancy following liposuction alone, which may require secondary skin excisional surgery, particularly those having poor skin elasticity. So I usually tell them to wait for about a year or so, and if still they feel that excess skin is there, we can always take care of that. Thank you so much.
Thank you, sir. Thank you very much. Any question, please?
Yes.
I would like to invite. Okay.
We have seen liposuction even at the age of 12 years, 13 years. So what is the advice for those patients?
The gynecomastia.
Sorry, gynecomastia.
At 12 or 13 years.
The large grade 2, grade 3 gynecomastia.
I think there is no contraindication for doing liposuction in those cases. And then, of course, in every case when we do liposuction, we do assess whether some residual glandular tissue is left behind, and then we may have to do.
No. Whether the question is whether we have to do it or we have to wait for some time.
I think we should do it. If it is causing any psychological issues to the patient, we must go ahead and do it. There is no contraindication for it.
Thank you, sir. Yeah, Dr. Moraka.
Sir, how do you manage the excess skin, sir?
No, I don't do anything to the excess skin.
No.
So
you said that you may do it secondarily. So how do you do it?
none of my patients have come back, so I have never done it. But if it is required, then of course you can do perioral, or that is what I would like to do, rather than giving those inverted T scars or something.
Thank you, sir. Now I'd like to invite Dr. Sanjeev Uppal. He will be talking about hand burns.
A very good afternoon to all present here. First of all, I congratulate the organizing team under Dr. Rakesh, who has done such a wonderful job and made the arrangement in such a beautiful environment here. So, my presentation would be a controlled environment, indigenous approach in management of hand burns. As you know, burns of the hand occur to a disproportionate degree compared with the distribution of body surface area. And they may result from even a small burn, as hands are the functional unit. Optimal results in the hand burns depend on management in acute and subacute phases. Even with the consistent protocol-based approach, the results may vary from almost normal healing to a burn claw hand. So what are the goals of treatment in burns of the hand and their treatment? So first is the prevention of development of edema. Second is the prevention of development of contractures. Third is providing a stable skin cover. And the fourth one is a functional hand. That is the most important. So the conventional techniques which are being used are application of dressings with topical agents, placement of hand in a splint in proper position, hand exercises and physiotherapy in between the dressing changes, and now the application of some biological dressings or substitutes are being done. So we tried to do it in certain cases where our goal was to keep the hand fully functional and reduce the formation of contractures and deformities. Movie. So this is how we have seen as initial contact with a plastic surgeon, the hand burns look like. There's edema, there's peeling off of the superficial skin. Next. So this is how the initial cleaning and minimal debridement is being done. Next. And now this is something they envelop, the plastic envelopes, which are about 2 kg or 5 kg, which we usually see are available with any of the Karyana stores. So we got these right from the factory itself. Once they are closed, they are just made and there is no air inside. We did a kind of culture sensitivity test from inside the bag and it was negative. Because it's a compressed thing and a vacuum closure is there in the factory, so there is no bacteria inside the envelope. So we put that hand after application of the antibiotic cream or gel and then put it like this and close it from the proximal side. Next please. Next. And this is how within the envelope the patient kept on doing the movements and there was secretion which was being collected into this envelope, the plastic envelope, which we used to change maybe twice a day or even thrice a day if the secretions are much more and patient feels bad or we feel that the secretions are too much, the envelope was changed. And this is after the partial healing, as you see, all the movements are restored. The patient has been doing continuous physiotherapy. Next please. Yeah, back to the presentation. So this is how the regular assessment of the wound is being done: day 0, day 2nd, day 5th, and day 2, 3, and 5. In a way, because it was a closed environment, so oxygen was being consumed, and this acted as an anaerobic environment for the aerobic bacteria to grow. So cost is negligible if we compare it with the negative pressure wound therapy. If we see about the growth of the bacteria versus the normal as we do, it's less than 100 rupees cost comes with the all kind of envelopes together. So this is a case which is 58 years of female, history of accidental burns over left hand while working in the kitchen, no history of any chronic debilitating illness like diabetes and all. So this is how the healing was there. This is day 2 of the therapy, day 0 and day 2, then day 3, then day 4, day 5, and after 7 days it's like this, and after sometimes the healing occurred spontaneously. So optimal management of the hand burns is an important aspect of burn management. Apart from healing of the wounds, a functional hand should be aimed, and the role of physiotherapy is very important for outcome of management. This way the physiotherapy keeps on going, the patient himself or herself keeps on doing the movements. The conventional approach hampers the regular wound assessment because it's covered with a dressing, and physiotherapy cannot be done because of the dressing as well as some pain which is there. And sometimes the physiotherapists are quite aggressive. They feel that some more exercises should be done. They go beyond the pain limit, and the patients, they then do not comply with the physiotherapy instructions. So this is how the studies have shown that development of edema hampers physiotherapy and increases the chances of contractures. And this approach allows initiation of early and vigorous physiotherapy. It creates an anaerobic environment around the wound, and it's a very low-cost approach. Thank you.
I just want to ask one question. So we are starting this on day 1?
Yes, we start on day 0, once the patient approaches.
Okay, so what I feel is on the first day, the patient has so much pain that active physiotherapy may not be possible.
Whatever movements the patient can do, he or she does it. The pain, of course, pain is the restricting factor, both ways. Even if the physiotherapist comes, he might force you do it this way, but here as shown the videos, the patient keeps on moving the fingers. And of course, we have to raise the hand a bit, which patient does himself or herself. Whatever movement he does.
So did you compare this particular management with something like a collagen sheet dressing and starting the physiotherapy after 7 days?
No, there was no comparison. This was the limitation of this study, that we didn't compare it with the standard treatment for this purpose. But of course it can be done, but that is another thing of healing with the collagen sheet. It will not affect the movements of physiotherapy as such.
So you are not sterilizing the bag?
We are not sterilizing the bag because it's already coming from factory. It's layer to layer, it's almost pasted with a vacuum. The way they make the bags, it is the inner side of the bags are compressed, and we tested the inner side with a kind of swab, microbiology swab.
And this treatment is only for the first, secondary supervision?
Yes, of course, not for third degree.
Thank you, sir. Thank you very much.
Inviting us here. So, this is the technique that we developed almost 5 years ago. We have done a small publication on this also. So, traditionally, there are around 211 published sutureless anastomotic techniques, and people have used various kind of things, lasers and glue and everything they have done, but it has not withstood the test of time. And there are almost 475 technology patents of various types of anastomotic techniques by using instruments. Like this laser-assisted anastomosis, fibrin glue. There is a unilink system, what anastomotic couplers are being used routinely, costing around 20,000 rupees, and it also takes around 7 minutes time on an average for doing the anastomosis with these couplers. Vacuum-assisted microvascular anastocoupler, vascular closure staples, everything is there. People have used magnets also. So these are the traditional things that have been used. There are anasto clips for doing creation of fistulas and anastomosis in the renal arteries, renal veins. So they have used and they are publicly available. But we are just thinking that is there any way in which we can simplify it and make it very low cost and make it very safe. So this idea came to the mind that we can use these Liga clips which are used to clamp the vessels. We can use these circumferentially in the vessel in a particular design. So first I had to draw the diagrams and then figure out the technique. And then we just came up with the idea and tried it in some ways. This is the video. I can
Approximately 120 degrees apart. One of the ends of each suture is left long for handling the vessel. The assistant holds the suture which is directly opposite to the surgeon and on the under surface of the vessels to prevent the back wall from getting caught during the clip application. The operating surgeon holds one of the sutures and applies the vascular ligation clip, leaving around 1 millimeter of circumference for the application of the next clip. This approximates and inverts the vessel edges at the same time. The vessels are rotated towards the main operating surgeon by 120 degrees each time, and 2 more clips are applied in the similar fashion, achieving a non-collapsible triangular anastomosis. This saline inflation test demonstrates a completely watertight closure. Splitting the anastomosis demonstrates an intima-to-intima contact with no intraluminal suture material.
So the greatest part about this thing is it is extremely quick. If you just try it, you should be able to do any microvascular surgeon should be able to do it in 3 to 4 minutes. There is no suture material inside. These clips are already being used for vessels, and you have to have another suture that is to be opened, making it extremely low cost anastomosis, and sometimes we have finished anastomosis in 2.5 minutes. Just 3 stitches and 3 clips. The only caution is when we are doing it, it should not be tried if the vessels are very tight and you don't have any spare length available, because if you go wrong, then you might be in trouble. But if there is vessels are lax, you can use it, and till date, we have had no failure in last 5 years. We have used in more than 200 cases. In 2-year-olds, from 2-year-old children to 80-year-old people we have used. There has not been a single failure in our flaps. Using with single vein as well as both veins. We have done arteries also, but it is only possible in arteries if they are pliable and in younger people. Atherosclerosis arteries you can't do with that. So this is the
clinical demonstration of this technique when the vessels to be joined are of almost similar size. Here again, the 3 stitches are applied at 120 degrees apart, and thereafter the vessel is rotated towards the surgeon and 3 vascular ligation clips are applied. Then the double clamp is removed and the vascular patency test is performed, showing good blood flow. This coupling technique could also be used when there is vessel size discrepancy. First, the external diameter of the vessels are measured. Then, in the similar fashion, 3 stitches are taken at the vessel circumference at 120 degrees apart. Here we can see the discrepancy in the vessel circumference. Nevertheless, the stitch is taken, and when the vascular clip is applied, the extra circumference of the larger vessel remains outside the anastomosis. The extra circumference of the larger vessel everts outside and is excluded from the anastomosis. And again, a triangular anastomosis is achieved. Once the clamps are released, we can again see a very good vascular patency. Now, this technique could also be utilized for coupling very small vessels, especially in pediatric microsurgery. When the vessels are very small, then in the similar fashion, we take 3 stitches 120-degree apart on the circumference of the vessel. And if the clip is of larger size, the extra length of the clip remains protruding outside the circumference of the vessel. So the full length of the clip does not engage the vessel, and still the anastomosis could be done very easily. In this particular case, we have removed the double clamp for ease and doing the coupling using the single microvascular clamps. Again, the patency tests show a very good blood flow across the anastomotic site, confirming the utility of this technique.
The only situations we have not used this is in digital replants, because the clip's thickness is too much and we find it unsafe. But technically, if the clip size can be reduced even further, less than the established micro Liga clips which we have, it can be easily used in that also. So this is, in my understanding, this is very revolutionary in the sense that anybody can use it. It takes such a less time, and there is absolutely no failure till date. And we have done long-term patency with color Doppler examination. First, before that, I just show the diagram that once you take 120-degree stitches at the circumference, you first put a clip and then you turn the vessel towards yourself and you leave almost a 1 millimeter gap so that you can apply the next clip, and you keep on turning the vessel and 3 clips are placed. Although there are questions that okay, a circumferential circular thing is converted into triangular thing, but as such there is always, we are doing anastomosis in various discrepant vessels, and there are a lot of techniques for it to correct the dog ears of the vessels by either clips or cutting it out. So this also reduces the diameter a little bit, but the flow is seamless because there is nothing inside the lumen. So this is a few more situations in which how it looks when you turn the thing. It's a triangle, and that also is non-collapsible because it is all, it's like a tripod thing, it never collapses because the clips are opposing each other. So this is how it looks after doing the anastomosis. And these are few more cases just to demonstrate that it nicely keeps on working just like any other coupler. And there are innumerable clinical situations we have used it. This is a long-term color Doppler examination at the site of anastomosis, and then it is showing the patency. So if we just see the coupler anastomosis, the incidence of thrombosis is less than 3%. Suture anastomosis is 3 to 10%. But in this particular clip anastomosis, till date, and more than 200 other centers are also doing it. In Cochin also, our teams are doing it. So we have not found any failure so far. And the time taken for suture anastomosis on an average is 21 to 48 minutes in large review articles. The coupler anastomosis takes 3 to 10 minutes time on an average. And this anastomosis 3 to 7 minutes. But if you master, your assistant is good and has been assisting you for long, it can be done much quicker, sometimes around 2 minutes also. And the cost is significantly different. You have you have to pay for 3 Liga clips and 1 suture, which you have to take for taking 3 stitches. So, which is very reasonable. Which I just said that we have not used it in digital replants, but in all other routine free flaps we have been using it almost every day. And it could revolutionize the microvascular coupling in a different fashion, and it can make it accessible to everybody. Thank you very much. This is a small article that we have published in JPRAS. The larger study as well as the larger article is underway that we are going to publish.
Thank you, Dr. Mohit. Wonderful presentation.
As always, good presentations. Dr. Mohit, how do you ensure, other than pulling the threads, not taking the posterior wall? Is there any other way? Because you are just pulling these two sutures.
3.
Are you putting the third one also?
Yeah, 3 sutures.
No, you are just pulling the
Yes.
third one also.
The first, surgeon holds with the left hand 1 stitch.
Oh, yeah.
The assistant with the 2 hands hold the 2 stitches.
Yeah, so you are putting all 3.
With your right hand or whatever left hand, whatever you are, you just apply first clip and then keep on turning.
Okay.
So
you
all
are
the
putting
3
all
are
3 sutures.
All the 3.
Any questions, please?
Yeah.
How do you adjust that part and there is no crumpling happening?
That's what I showed in the video. Suppose one circumference is bigger and this is smaller.
Yeah.
So you just ignore the larger circumference. For the larger vessel, you take 120, 120, 120 stitch. You just match the circumference to circumference, however discrepant it is. When you pull the stitch, the larger vessel wall just keeps on hanging. So you engage the lesser vessel. At the level of the smaller vessel you engage. All the larger circumference keeps on remaining protruding outside. It doesn't get engaged in the anastomosis. So it just hangs outside and is excluded from the anastomosis. I think it's best tried in laboratory or in some extra vein, and you will come to know that how it happens. That the larger vessel is also not a problem. But if you are uncomfortable initially, you may just avoid it and do it in the similar size vessel to get used to it. But it's very easy to get used to it. In any spare vein, you can just sit with the microscope and 5 minutes you will realize, oh, this can be easily done, and then you start doing it.
Thank you.
Is there any leakage in between these clips?
If you do not apply it properly, so it's all visualization. If you just see, keep your hand steady, and then just apply it. So we are used to keeping our hands steady. But if you leave some more gap, then there may be some leakage. You just put 1 stitch at that side. But usually we have not required. Only in maybe one situation I would have put some stitch. If you just apply accurately, veins don't have that much of pressure also. So they just work.
Sir, had you tried for end to side also sometimes?
Not in end to side. We have not tried. But technically should be possible. With the same way. Should be possible, but we have not tried. Now, on your suggestion, I am definitely.
So this paper has a voiceover. So my job basically is to stand here and look intelligent. Rest everything is there, and I'll be happy to answer any questions at the end.
Required can affect a patient's sense of balance, body image, and quality of life. Addressing asymmetry requires a meticulous approach that considers both aesthetics and function. This talk will cover the essential elements of planning and executing corrective surgery for breast asymmetry, including surgical options, patient assessment, and tailored techniques to achieve optimal outcomes. I have no financial disclosures or affiliations to any commercial interests. The definition of an ideal breast varies from culture to ethnicity. The ideal breasts are symmetrical and proportionate in relation to the body. This slide highlights the attributes of an ideal breast. Amongst other things, characteristics that define an ideal breast are sloping or full upper pole and a gently curved lower pole with an NSE at the point of maximum projection. The key landmarks are the IMF, the NSE, and the suprasternal notch. In the ideal breast form, the nipple areolar complex should be cephalic to the level of the inframammary fold. Breasts are an integral part of feminine beauty, and breast symmetry is key to beautiful form. Mild asymmetry is common, but significant asymmetry can impact a patient's psychological well-being and body confidence. A young woman with severely asymmetric or uneven breast development is likely to be profoundly self-conscious. Breast size and shape can be affected by all of these, including physiological changes occurring during pregnancy and breastfeeding. The key to successful treatment are defining the nature of the breast asymmetry, respecting the patient's aesthetic goals, and performing a well-thought-out surgical plan. The surgeon needs to establish rapport and trust by understanding her concerns and pre- and post-operative photos of other patients treated for similar problems. Breast asymmetry is common and can be very distressing. All components need careful assessment. This requires careful surgical planning, including identifying all the asymmetries, and the correction involves a number of surgical techniques and may require more than one surgery. Breasts are an integral part of feminine beauty, and breast symmetry is a key to beautiful form. A young woman with severely asymmetric or uneven breast development is likely to be profoundly self-conscious. For such a woman, surgical intervention can be life-changing. Breast asymmetry is when one breast differs in shape, size, or position from the other. It may be congenital or acquired. These breasts are a result of errors in growth and development. Size asymmetry is usually obvious. Other asymmetry to consider are shape, position, nipple areolar complex, and the degree of ptosis and the level of IMF. It is important to exclude postural and chest wall asymmetries. The approach to breast asymmetry has to be meticulous, as can be seen in this case, where implant expander reconstruction has not resulted in a favorable outcome. These are post-mastectomy breast asymmetries. Proper evaluation is crucial for successful surgical outcome. Understand the patient's goals, concerns, and expectations. Discuss potential outcomes and limitations. Examine the patient in both seated and lying position to understand the breast's natural behavior. Detailed clear photographs and a realistic management plan needs to be formulated. The surgery for correction may need to be staged, and radiological examination may include a high-resolution ultrasound or an MRI, which can also give you a volumetric assessment of the breast. Aesthetic surgery simulator software can help in educating and communicating with the patient and also works as a marketing tool, but it does not in any case replace proper tissue planning and patient assessment. This is a very useful article to read and gives insights on how to manage breast asymmetry. Another article that talks about patient and surgeon reported outcomes after asymmetry correction. The aesthetics item scale. The patient and surgeon reported outcomes vary as patient lay more emphasis to volume and shape while surgeons prioritize scars. These are some important measurements and landmarks to keep in mind while examining the patient. These are the 5 pillars for a consistent outcome: calibrate patient's expectations, under-promise and over-deliver. As plastic surgeons, we have a lot more in our armamentarium and can choose from a variety of procedures to breast asymmetry. That includes liposuction, lipofilling, NSA reduction or relocation, shifting the IMF fold, mastopexy, reduction, combination of these procedures or implant augmentation, and as well as expander implant reconstruction. We are not far off when tissue engineering may deliver customized reconstruction in such cases. A large fibroadenoma causing gross asymmetry, treated with removal via periorbital scar, the correction of the breast asymmetry can be appreciated. This is the asymmetry of breast size, shape and nipple. She did not want any scars on the breast and had reasonable expectations. We marked out the areas of the breast requiring fat transfer and liposuctioning fat from the unwanted areas like the axillary roll of fat. A periovular reduction of the NSE of the left side was done, including fat transfer. There is an appreciable improvement and the breasts look more aesthetic. The left breast is appreciably smaller than the right side. We considered about implant augmentation on the right side and mastopexy on the left side. The family did not want any scar on the chest, so reduction mammoplasty was not done on the left side. Here there is asymmetry of breast size, shape and doses. We have to customize the treatment based on patient's wishes. Right side breast augmentation and left side breast reduction resulted in a fairly symmetrical breast. It is important to discuss all available options with the patients and follow the concept of shared decision making where the patient is an equal partner in deciding the nature of the surgery. This is Baker grade 4 capsular contracture that resulted in severe pain because of scar. There is a distortion of the breast and it was very firm, too hard to touch. A total capsulectomy with implant exchange was planned. The thick fibrotic capsule is keeping the breast taut. The thick fibrous capsule can be seen and a total capsulectomy was done and part of the capsule along with the fluid was sent for histopathological examination. This shows the explanted implant and the capsule. This is a 3-week post-op result. Balance and symmetry of the breast can be appreciated. This is an 18-year-old girl with 20 kg of weight loss with diet and exercise. The breasts are distorted and asymmetrical with shape and volume difference. The result after a bilateral reduction mammoplasty with aesthetic and symmetrical looking breast. A 44-year-old patient with gross asymmetry of the breast. The asymmetry became more pronounced after the birth of the second child. A differential breast tissue was excised using Hall-Fendley vertical scar reduction mammoplasty. Excision of 1350 grams of breast tissue from the right and only 500 grams from the left side. The on-table photograph shows a fairly symmetrical breast. This is the post-op at 7 days. She was happy with the overall symmetry and balance of her breast. This is an inadequate breast reconstruction using LD muscle alone post-mastectomy. You can appreciate the gross asymmetry and mismatch in breast size. The footprint of the breast on the left side is matched to the normal right side. We planned a 2-stage procedure using tissue expander to create adequate size skin envelope and scaffold followed by breast implant. A 500 cc round expander was used in the first stage. The left breast was expanded to create the desired breast volume and required 18 sittings of saline fields at 7 to 10 days interval. The skin is overexpanded by 30% to achieve post-optosis of the breast. We like to wait for 4 to 6 weeks after the last expansion to allow the skin to mature. These are the pictures before expander exchange with the implant along with fat transfer. Please appreciate the extra skin which has been generated. A cohesive gel-filled anatomical breast implant of 405 mils was used. Also note the gentle slope of the upper pole of the reconstructed breast and ptosis akin to a normal breast. A fairly symmetrical breast shape has been achieved. This is another patient showing complete absence of the left breast, what we commonly know as Poland syndrome. Again, the footprint has been replicated on the left side. The required skin and volume has been created using a tissue expander, and the final result with a breast implant and a very happy patient. Another patient with severely hypoplastic left breast with pectus excavatum. She was 35 years old when she came to us, and this shows the patient after tissue expanded to the left breast. She was desirous of increase in size of the normal right breast as well. Correction of step deformity between the breast and the upper chest and pectus excavatum was done with lipo injection along with breast implants to both sides. Implants were placed in subgranular plane. A balanced and symmetrical result can be appreciated. Even the NSE has increased in size post-expansion and the breasts are very symmetrical. These are some of the takeaways from this talk. Breast asymmetry correction demands a meticulous, patient-centered approach that balances aesthetics with realistic expectations. By thoroughly assessing patients' unique anatomy and goals, surgeons can deliver results that not only restore physical symmetry but also greatly enhance the patient's confidence and quality of life. Calibrate the patient's expectations with shared decision-making. And always remember, as a plastic surgeon, under-promise and over-deliver. I stand before you today seeking your support for the role of Vice President of the Association of Plastic Surgeons of India. My journey with APSI began many years ago as a member. Over time, I have had the privilege of serving as an EC member and most recently as the President of the Indian Association of Aesthetic Plastic Surgeons in 2024. During my presidency, I had the honor of representing IAPS at the National Medical Commission, where I worked hard to secure our surgical privileges and strengthen our domain. I also led efforts to streamline operations and successfully conceptualized the Journal of Aesthetic Surgery, which is now taking shape as the International Journal of Aesthetic Plastic Surgery. One of the proudest moments of 2024 was the ACES 2024 conference in Delhi. With over 460 participants and 150 new members, the conference saw the participation of 8 global societies. This was an incredible opportunity to showcase Indian talent on a global stage. In my commitment to creating a stronger global presence for Indian plastic surgery, I had the privilege of leading 24 Indian aesthetic plastic surgeons to Berlin for a joint meeting with the German Aesthetic Society in June of 2023. I am proud to share that 30% of the podium presentations were delivered by colleagues from India, showcasing our expertise and excellence. I have also served on the IMCAS board member in 2023-2024, and in 2025 I will be honored to join prestigious international events including the World Society of Reconstructive Microsurgery in Barcelona, Spain, and the ISAPS Olympiad in Singapore as invited faculty and speaker. As a reconstructive microsurgeon and educator, I have trained numerous DMD surgeons, many of whom are now doing remarkable work in the field. With over 300 presentations at national and international conferences, I have always been committed to advancing our field and sharing knowledge. If I am elected as Vice President of APSI, I will work tirelessly to elevate our association both nationally and globally. The focus will be on establishing partnerships with leading global societies, making it easier for our members to access fellowships, training, and collaborative opportunities. Providing more opportunities for younger surgeons to grow through access to international journals, webinars, and connections with world leaders in our field. Promoting the outstanding work of our surgeons on the global stage and driving forward medical tourism in plastic surgery. Together we can take APSI to great heights and make our association even more relevant and impactful. I humbly ask for your support so that I can continue working for you and for the future of our profession. Thank you.
Thank you, Dr. Sudeep. I think we are running short of time, so now we won't take any questions.
Thank you.
I would like to invite Dr. Mahesh Mangal for the next talk. He'll be talking about mucormycosis, a challenge to surgery. Mahesh sir.